we'll have debate between myself and Dr. Nizar about which is much better if you have new patient to start with combination therapy, as Dr. DiFranzo believe, or to have, metformin. If it's not going to work, to add one more medicine, they call it add-on. Oh, I'm sorry. Management of type 2 diabetes, that's my talk. Oh, what I am doing, I don't know. Okay, so you could start as what you call it add-on therapy. You could just, I don't know, I need maybe some help. So you could start as what you call it add-on. No, next one. Which one to push? Oh, this one. Yeah, okay. Yeah, okay. Add-on, basically, you could start with metformin. If it's not enough, you could add one more medicine. If it's not enough, you could add injection. If it's not enough, you could add insulin. The famous combination came basically from Dr. DiFranzo and Dr. Muhammad Abdelghani. Usually they have old cocktail. They start with metformin, plus the same time with pioglitazone, plus the same time exenatide. And now they have a new cocktail, came just recently. The cocktail is basically SGL2 inhibitor, plus pioglitazone or metformin, plus DDP4 inhibitor or GLP-1 receptor agonist. So what I'm going to do, we'll see, the evidence of my part and Dr. Nizar part, and it is up to you to decide which is really the much better way to start the medication. Diabetes, as we know very well, is a leading cause of death everywhere, and usually the cause is coronary heart disease. And the question always, if decreasing blood sugar will lead to decrease of complication and mainly the heart disease, honestly, we did not know until just recently. 94, it was the first time we know yes, and for type 2 diabetes, UKBDS shows that yes in 98. And UKBDS now, everybody knows, is the most important, one of the most important study in the history, not only in diabetes, the history of medicine. And the only medicine until 2015, the only trial until 2015 to prove that controlling blood sugar will decrease mortality, it was only UKBDS. UKBDS, basically, the first, what you call it, the first UKBDS came in 1998, and then after a follow-up 10 years, again, 2000, I guess, and 8. What, okay, for my evidence, let's see, it is the only study which proved that could decrease mortality. How they did it? They did it, metformin in a small group of patients proved to decrease not only cardiac complication, but total mortality. But the real study involved about 4,000 patients. They added in the old-fashioned way. Start sulfonylurea. If it's not good, add metformin. If it's not good, add insulin. At that time, it was more common MPH. And the study showed by decreasing 1% of hemoglobin A1c, you will be able to decrease macrovascular complication in significant way by 37%. MI, 14%, but it was not significant. Follow-up for 10 years, it turned to be significant. Okay, and then say, what about if we control hemoglobin in a more significant way, less, instead of 7, let's make it 6.5. And came 3 major study, a cord study, advanced study, VAD study, and the surprise was no improvement in cardiovascular or total mortality. And in a core study, as a matter of fact, we have increased mortality in the group of intensive treatment. It was a surprise. What could be the cause? They said maybe hypoglycemia, maybe medications, in particular diabetic drug, and maybe gaining weight. Now let's see what the guidelines say. UKPDS said start as add-on, metformin and sulfonylurea and so on. Now let's see what the guidelines say. The guideline was very simple message. Start with metformin and wait. If you need to add one more, you could add whatever you like until recently. So you could start metformin, you have to start metformin. And second line, any medicine available in the market. Combination, yes. If hemoglobin A1C more than 9%, insulin, yes. If hemoglobin A1C more than 10%. And then came the shock in what you call it a Vandia storm, which came 2007, and then the shock of a cardiac study, which forced the FDA to have a new guideline. No new medicine will be allowed unless you prove no harm. Not necessary to prove benefit, but at least you have to prove there's no harm. And we had a lot of study involving since that time, involving about 150,000 patients. And Napoleon was not very happy because we did not have, honestly, not even one single drug showed that they able to decrease mortality or cardiac complication until recently. Recently, just 2015, in Sweden, I guess, they announced the reg. And last year, they announced leader try. For the first time in history of diabetes, we proved that there is one anti-diabetic medication could decrease cardiac mortality and total mortality. And there is excellent review about this subject. It just came from Jack, okay, about diabetic medication and cardiovascular disease. So according to Sataru, who published this article, now we could say that metformin, pioglitazone, and IMPA, and Victoza could provide cardiovascular benefit. And according to him, maybe sulfonylurea, glitazone, DPP-4 inhibitor, congestive heart failure, and insulin maybe will provide, increased risk of cardiovascular disease. So is it time to change the guideline? The answer, yes. Is it time to fire metformin? The answer, no. Metformin is old and boring, no question about it. But it is the only medicine until recently proved to decrease cardiovascular mortality and cardiac complication, and it is very cheap. We have very severe, not very intense and hot debate in the last meeting in Orlando, from this one from Boston for metformin, and this from Canada basically said it is time to change metformin as first line. But ADA still believe metformin is still the first line of treatment. For second line of treatment, as we know that, if patients have poor controlled diabetes and you have to add one more medicine, you could add now GLP-1 agonist and CGL inhibitor. The trend now to use less sulfonylurea and more GLP-2 inhibitor and GLP-1 receptor agonist. Is it time? Okay, first line, no, we answered no, I'm sorry. I'm doing the same, okay. is it time to change the guideline? Yes, that is in process. They will announce the new one basically in Berlin, in Germany, in September or 1st of October. Now, one more evidence, if you use a lot of medication, it is harmful, especially for the old people. And this study, which came in JAMA, showed that 50% of the medication is useless, using for old people. And the old people, they have more tendency to develop hypoglycemia, and hypoglycemia, they have more tendency to produce damage. A core study, we know everybody now, I'm not going to waste your time. In a core study, they use a lot of combination, and especially use actazone and insulin. We talk about the old people. I don't know what I am doing. Okay, I am sorry if I am confusing you, or I am sorry if you kept you not awake. Is cost important? Yes, you cannot practice the same medicine like in the United States when they have national income 50,000, or in Qatar or Gulf area is income about 80,000, and Morocco about $300. You cannot practice the same medicine. You cannot follow the same guideline. And I thank Dr. Musbah because he gave me this slide. And the cost of patient with diabetes, basically in USA about, in Western world about $10,000, in the Gulf about $2,000, and in Egypt and Morocco about $160, $200. You cannot practice the same medicine. You have to follow this logic. I mean, what is striking to me, Israel is the cost for, I mean, spend more dollar for the patient than us, the Gulf area. How do you explain it? I don't know. Medication, the old medication, metformin and sulfonylurea, it is very cheap, $10. The new medication, which we have a lot of lecture about it, it costs about $1,000. I'm talking about 3 months medication. See, I mean, this issue always bothered me. The drug company like to push us, encourage us to use a new medication, expensive medication. The guideline, the medical insurance push us to use a cheap medication. What about the consumer? Malun al-Allah in our area. So, Dr. DeFranco and Dr. Nizar, it cost his way, the old way, about $2,000, and my way, it cost only $200 for 3 months. And Dr. Nizar liked to use more advanced medicine, and it cost about $3,000, and my way, it cost only $200. Dr. Nizar, very cheap. I am not very cheap, I'm sorry. I mean, I am very cheap, yeah. Always remember when you are dealing with new medicine, the Avandia. The Avandia basically, okay, always practice little Descartes, little doubt, okay? Always, please. Those who don't know history are doomed to repeat it. So the combination, basically, the only advantage in my mind of combination therapy, that maybe will give you much better control over longer of time. But there is no clinical evidence you could translate it to cardiovascular benefit or to decrease in complication. And the evidence limited to 2 years. And now Dr. Abdel Ghani and Dr. Amin Jayousi present case in ADA for 4 years. So now, just, I mean, you practicing, and patient came 40 years, and he had diabetes in you, and his fasting blood sugar 145. Would you use 3 medicine and 1 injection? Would any patient accept that? Dr. Nizar, you will tell us. The real question is basically which drug for which patient and when. Chairman Mao used to believe one size is fit for all. But we know now Chairman Mao was not correct. وما أوتيتم من العلم إلا قليلا. And thank you for nice attention.